we heard many times Dr. Simon Heller. Many credits to his name, and I think so. He's a known name among the Indian fraternity also. And but nevertheless, Simon Heller is a professor of clinical diabetes at University of Sheffield, and he's a director, research and development, and honorary consultant physician at Sheffield Teaching Hospital Foundation Trust, UK. And he was editor of Diabetes in Medicine, and he conducts a research program concerned with the developing a Daphne intervention. And I think so in light of today's talk, actually, his research regarding the Daphne intervention will really help us to understand more about the hypoglycemia. And his talk is on hypoglycemia, and technology alone is not enough to solve the problem. So in this conference itself, we heard many technological advances, and technology has really gained in momentum since last 10 years time. But still, we have a very senior and very learned speaker who will throw a lot of light on hypoglycemia. Over to you, sir.
Thank you very much for those kind words, and it's a pleasure to be asked to participate in this great meeting. So I'm going to share my screen. And I just want to confirm.
Yes, your screen is absolutely visible and you are loud and clear, sir.
Great, thank you very much. So as you've heard, my title is Technology Alone is Not Enough to Solve the Problem. And these are my disclosures. And this is the outline of my talk. I'm very briefly going to remind you about the epidemiology of hypoglycemia and defining the problem. And then one by one, I want to consider the potential benefits, sadly, very briefly, but we may have time to enlarge this in discussion about technology, which is truly transforming the clinical picture of diabetes across the world. But to remind you of the benefit of new insulins, of course, where they can be afforded, and to also impress upon the audience, which I need to remind myself every day, is that education is a very effective way of reducing hypoglycemia. Now, we have heard and seen technology, and that includes new insulins, transforming the last 20 to 30 years of diabetes. And you might imagine, as some clinical trials have shown, that this has made a big difference. The DCCT, I think, was the first study which proved that microvascular disease and eventually macrovascular disease, at least at those in early stages of diabetes, could be reduced by intensive glycemic control. And the price that was paid for those benefits back in the early 1990s was a really high rate of severe hypoglycemia. To remind you that severe hypoglycemia being defined as needing the help of another person to recover. So you can see a threefold increase in severe episodes in the 1990s, which brought glycemic benefits. If we forward to a fairly recent study, you can see that using sensor-augmented pump therapy could reduce hypoglycemia, but look at the frequency in both the controls and the patients in the intervention group. And you can see marked reductions in severe hypoglycemia. And you may therefore conclude that technology has solved the problem of hypoglycemia. But if we look at real-world data, and by that I mean the kind of episodes of hypoglycemia which are being recorded in clinical practice on a daily basis, and this is in the Western world, Europe and North America, you can see that the frequency of hypoglycemia, one, is greater than the DCCT, and sadly has hardly changed at all in the last few years. And you might say, well, the last study was about 8 years ago. It's probably not as bad as all that. But I could show you data from the HAT study. But this is a study presented as a poster in the recent virtual ESD meeting. It was from Stuart Harris's group in Canada, and they did a survey of over 1,000 patients from North America, USA to be precise, and measured the incident rate, the same events per person per year, and the proportion, again, the same. And it also includes people with type 2 diabetes. And I think these are remarkable and worrying findings, because what they show in everyday clinical practice that we have made almost no improvement over the last 30 years. In their type 1 population, 3.5 that severe hypoglycemia in type 2s is about a third, but these data show that it's over 50% as high. And if we look at the proportion, you can see half the patients with type 1 and a third of those with type 2 have had a severe event over the previous 12 years. Not only that, but the percentage of severe events which resulted in hospitalization was only around 4%. 90% were treated outside of the hospital, and of those, 50% of those were treated at home. So the burden on the family and the friends is huge, and shows we have a very big job to do in improving things. Now, this audience knows the effects of hypoglycemia on the central nervous system, how it increases the risk of road traffic accidents. And in recent years, we and others have shown that hypoglycemia almost certainly has adverse effects on the cardiovascular system, which probably limits the benefits of tight glycemic control, at least when using insulin and probably sulfonylureas. But we can address hypoglycemia, and I want to take these three areas one by one. First, very briefly, just show you some examples of how technology could and has reduced hypoglycemia, remind you of the potential of newer insulins, and then finish by also reminding you about education. So let's take technology. And certainly in many countries across certainly Europe and in North America, continuous glucose monitoring, as shown by flash glucose monitoring and the Libre device, has transformed the clinical landscape. And now around 40 to 50% of type 1 patients in the UK are using these devices. Yet if we look at the evidence base for continuous glucose monitoring, it is rather limited, particularly in terms of randomized controlled trials. Nevertheless, I want to draw your attention to this study published in The Lancet fairly recently. They took 241 adults with type 1 diabetes. You'll note that these patients had pretty tight control to start with. Their mean A1C was 7.5%, and they were randomized to either use the Libre or conventional blood glucose monitoring, measuring outcomes at 6 months. There was no real difference in severe hypoglycemia, and their outcome was the hours per day less than around 70 milligrams per deciliter. You'll notice that HbA1c didn't change. It remained around the 7.4% mark, but there was a modest reduction in glucose below 70 over the course of the study, which was significant. So a really modest benefit. And if we look at RCTs, we struggle to see the benefit, although in clinical practice, many patients say this has really improved their quality of life. Another study, I think, showing that if you take those most severely affected, then you can make a difference. But this is not a randomized study. This is a study published in Diabetes Care. 35 patients with impaired awareness of hypoglycemia is defined by the GOLD score and the effect on using on pumps or MDI, despite aggressive education, still having significant hypoglycemia. And when they were treated with a CGM device, they could show this improvement, as you can see on the right, in terms of hypoglycemic episodes in people with impaired awareness. So in non-randomized studies, we can definitely show benefit. But technology isn't always been shown to be successful, and people fail to cite these studies. This is the Hypocompass study. It was a 2x2 factorial, which compared simple education, a couple of hours, weekly support from a healthcare professional in all these patients, and some were randomized to pumps, some were randomized to pumps plus CGM, and the results are shown on this slide. And please note the changes in these groups. The first thing to say is that if we looked at those randomized to pumps or MDI, there was no difference compared to those who received education and support. And in terms of other benefits, education did just as well. And you'll notice the p-values are all non-significant for all these outcomes, whether it's annualized rate of severe hypoglycemia, the proportion affected, and the impaired GOLD score. So what it's showing is that education is just as effective in a randomized trial as technology. Here's another study which we published in the BMJ just 3 years ago. We compared insulin pumps versus MDI in adults with type 1 diabetes in a cluster randomized controlled trial published in the British Medical Journal. Both groups received structured education. One group received pumps, and there were no additional benefits in terms of glycemic control or psychosocial outcomes, and no difference in severe hypoglycemia. And yet, in both treatment groups, the number of severe events was reduced by around 50%. The incident rate ratio altogether was 0.46, and the reduction was the same in both groups. Education is cheap, extremely cost effective, and at least in patients who have yet to receive education, there is no benefit of pumps. So what else can we do? How can we treat our patients more effectively? Just a couple of slides on the potential benefit of insulin analogs, which I think is important. This is a study in type 1 diabetes. It was a randomized crossover study in patients at increased risk of severe hypoglycemia. And I would say in passing that we surely should be recruiting patients at high risk if we want to demonstrate the benefit of our interventions. You can see that in this study, there was a 30% relative risk reduction in terms of severe hypoglycemia, and indeed an absolute risk reduction of 0.5 severe episode per patient per year. And you can see shown in, highlighted in gray, that the benefit is in reducing hypoglycemia through the night, if you look during the daytime, the differences are much less marked, and indeed, in some you don't see any at all. The benefit is in reducing hypoglycemia at night for those at high risk of severe hypoglycemia. And this was comparing human insulin to insulin analogs, both rapid-acting and basal insulin as well. So the benefit at night, and if we look at one of the new modern insulins, I'm going to choose insulin degludec because this is a nice slide. You can see that if we look at the regulatory studies, the begin studies, switch 2, the crossover study, and lastly devote the large cardiovascular outcome trial, no difference in HbA1c. These were patients all aiming for tight glycemic control, some reduction in fasting plasma glucose, a variable change in dose, but a consistent reduction in hypoglycemia. And for devote, there was nearly a 40% reduction in the risk of severe episodes. So insulin analogs, when they can be afforded, will make a real difference. And finally, what's the evidence about improving education? The first study is a study in type 1 diabetes. It's from Michael Berger's group. And what it showed was the effect of structured training, their insulin treatment and training program, a 5-day inpatient course. And what you can see here, as was shown in the DCCT, this relationship between HbA1c as you come down, an increase in the risk of severe events in the year prior to the intervention, and in the year following the intervention, you can see that that relationship has been abolished. So merely teaching people to use their insulin safely and effectively in an intensive way can reduce the risk of severe hypoglycemia in those who strive for tight glycemic control. And I think these are really important data, which people tend to forget. Now, you may say to me, well, what about type 2 diabetes? I would concede that the evidence is fairly limited, but here's a study from South Korea in which they took 55 patients with type 2 diabetes on insulin or sulfonylureas. They randomized them after a standard educational program to an additional 1 hour of hypoeducation. And those who had the additional education are shown in the black squares. And you'll note that within 2 weeks, episodes of hypoglycemia less than 70 milligrams per deciliter were halved and remained so through the 24 weeks of the study. So again, evidence in type 2 diabetes that simple education of just 1 hour can make a real difference to hypoglycemic risk. So in my conclusions, before I have one other summary slide, I think that technology, new insulins, and education all have their place in addressing the problems of hypoglycemia, although inevitably most of the evidence has been accumulated in type 1 diabetes. Education in type 1 diabetes appears to be effective, much more cost effective, but sadly rarely adequately provided. And although we don't have a huge amount of evidence in type 2, I would suggest that what we do have suggests similar benefits. There are increasing alternatives to insulin in type 2 diabetes, as we've heard from the previous session today, but again, it's where they can be afforded. So what are we to do in terms of our clinical practice? Well, this was a systematic review published in Diabetes Care fairly recently. It only applies to type 1 diabetes, but some of the benefits are likely to accrue from those on insulin with type 2. So first and most effective is structured education in optimized, intensive, flexible insulin therapy using insulin analogs. and possibly blood glucose awareness training, which is what BGAT stands for. For those who still have problems, then pumps and possibly real-time continuous glucose monitoring could be added. And finally, for those, again, where it can be afforded, we now have very sophisticated technology, of which more in a minute. But probably the most important thing is very frequent contact and support from people who know how to manage hypoglycemia. So what is the future then in terms of technology? And this slide has been labeled Progress Towards an Artificial Pancreas and its Effect of Hypoglycemia. And it shows you 6 stages, of which we're probably now reaching stage 4. So the first pumps that we used were pumps which shut off when the patient didn't respond to their falling glucose, a combination of continuous glucose monitoring and pumps, which caused a 38% fall in nocturnal hypoglycemia. Then we had the predictive pumps from Medtronic, which could predict hypoglycemia based on the rate of fall of hypoglycemia, and that caused a 60% fall in events from a study published in 2017. The technology is becoming more sophisticated because now insulin doses above a certain glucose level can be added to reduce the risk of hyperglycemia. And then now we have the automated basal hybrid closed loop, the 670G, and a paper showing both a fall in glucose less than 70 and a greater fall in HbA1c. And we're on the verge over the next 10 years of seeing a fully automated insulin closed loop and a fully automated multi-hormone closed loop. Are these going to be the answer to our problem? Maybe in type 1 diabetes, but again, they're going to be incredibly expensive. But as we've been discussing this morning, giving insulin in infinite amounts to people with type 2 diabetes is going to be something to be carefully assessed, because I would suggest this alone is never going to solve the problem in type 2 diabetes. And with that, I'd like to thank you for your attention and look forward